Good morning to everyone. Good evening, wherever you are in the world. I'm very pleased to introduce this WFPICCS nursing webinar on the strategies to reduce moral distress and increase nursing retention among PICU nurses. So warm welcome to all of you. And I thank you for joining us on a topic which is really of increasing relevance for nurses around the world. Please, can you please mute the microphone? This would be amazing. Thank you so much. I am Ursula Gawronski, and I'm currently the WFPICCS Nursing Vice President. And just a few words about WFPICCS, which is the leading organization advocating for the care of critically ill and injured children globally. The WFPICCS mission is to advance professional knowledge, enhance healthcare providers' skills, and share best practices worldwide. So why this webinar? Well, evidence suggests a link between moral distress and occupational strain in relation to the retention of nurses. So the aim of this webinar is to discuss the topic of staffing and moral distress and what strategies have been applied to address them, particularly at the institutional and hospital level, and particularly considering the perspectives also of low and middle income countries. So I'm very pleased to introduce our four excellent speakers for today's webinar. First of all, Dr. Cinda Rushton from the United States, who is an international leader in bioethics and nursing and a professor of clinical ethics at the Johns Hopkins Berman Institute of Bioethics and School of Nursing. And she also co-chairs the Johns Hopkins Hospital's Ethics Committee and Consultation Service. She's also a founding member of the Berman Institute, and she's carried on many initiatives to transform moral distress into moral resilience. Then we have Dr. Andrew Argent, who has worked in critical care in Cape Town for more than 30 years until 2020, year in which he retired. And he used to direct the largest pediatric intensive care unit in Africa, and is also one of the past presidents of the World Federation of Pediatric and Intensive and Critical Care Societies. And Andrew has a particular interest in the provision of care to critically ill children and has implemented training programs for healthcare professionals in pediatric critical care worldwide. Then we have Janet Mattsson, who is a professor of critical care in Sweden at USN and is also currently the ESPNIC nursing president. And Janet has been working in the field of NICU and PICU since 1987. And her research mainly involves people's active participation and the participation from a nursing and health perspective in a high-tech environment. And then last but not least, we have Natalie Pattison. And Natalie is a clinical academic who has worked clinically in cancer and critical care outreach. She's a professor of clinical nursing with a joint appointment across the University of Hertfordshire and East and North Herts NHS Trust. She's a clinical lead for critical care follow-up services, and she combines this clinical role with her research role. And her research interest is critical care, end of life in critical care, staffing, and disability. So I will be moderating this webinar with Bistra Geleva, who is the Vice President of the Global Strategy and Advocacy of Children's HeartLink. And Bistra has worked at Children's HeartLink for many years and is a passionate advocate of improving access to care for children who need pediatric cardiac services. So welcome to all. And we will take questions at the end. So please use the Q&A function in the webinar to ask questions of the speakers. So at the end, we will have time for discussion, and we are ready to start. So I would like to invite Dr. Rushton to start her presentation. Thank you.
Well, thank you for that incredible introduction. And I always feel at home with my pediatric critical care colleagues because that's where I started my career a really long time ago. So it's always like coming home to my people. So just really happy to be here with you today and to have a chance for us to think about this issue together and to think about how we might discover some new ways to relate to these realities. I don't have any conflicts of interest. We do have a forthcoming book on our topic soon. So I want to start by just inviting us to just pause for a second and to really see if we can reorient to why we're doing this work and why it matters. Because in order for us to really think about how we can transform this moral suffering that we're experiencing, I think it's really important for us to reorient to our why. And I know most of you probably have many, many answers to that question of why this is how you've chosen to serve. But see if you can just take a moment and to remember that. And also to take stock of the incredible contributions that you've made, especially in these last 4 years, when we have had to pivot and to change in ways we never imagined we could, and to do things that seemed impossible at times, and yet we still showed up. So I just think it's really, really important to start with that acknowledgement for ourselves and for each other that the work that we do really makes a huge difference. And all you need to do is ask one of those children or their parents, and you'll have the answer. So given the realities of where we all practice, there is a lot of moral adversity. And when we think about moral adversity, it is a range of experiences that we can have in our clinical practice. It can be produced by internal or external circumstances. But generally, they're related to some kind of morally objectionable or troublesome or even unfortunate result that in some way or another challenges or imperils our integrity and well-being. So when you think about that opens up a lot of possibilities of things that we carry with us. And so just for a moment to think about what are the kinds of moral adversity that you face on a daily basis? How do they show up in your practice? What are the sources of those experiences? So just to take a moment for yourself. And, you know, if you'd like to put a few examples in the chat, that'd be great too. I'm sure that when we think about those sources of adversity, we have a lot of commonalities. And one of the ways that we respond to that moral adversity can be moral suffering. And the reason I use this context of moral suffering is that this whole landscape has expanded quite a bit, especially in the last 4 or 5 years. But in a broad sense, moral suffering is that anguish that we experience in response to moral harms. Sometimes there are things that we feel are just wrong. Sometimes it's a moral failure. And in other times, it's just an unrelieved moral stress. These kinds of experiences can be triggered by a whole host of experiences. Sometimes it's witnessing those transgressions ourselves. Sometimes it's when we participate in them, or even sometimes cause harm ourselves. And the outcome of that is that our integrity is threatened or violated in some way. So in our work, for some reason, it does not want to, hold on. In our work, we think about this on a continuum that starts with the experience of moral adversity. Initially, we may experience some moral stress. That's that sort of quivering recognition that something doesn't feel right. It's often experienced in our bodies and our hearts and minds. And sometimes we can relieve that stress just by, thinking through a situation, getting additional help. But a lot of times what happens is that progresses to moral distress. And moral distress, I heard recently, now has about 32 definitions. So I'm going to share one of them. One of them is recognizing a moral problem, seeing that I have responsibility to do something about it, reasoning about what I should do, but not being able to act on it because of either internal or external constraints. And that is probably the most well-researched cause of moral suffering. But increasingly, what we are learning more about, and particularly during COVID, is moral injury, which is a more corrosive form of moral suffering that involves transgressions, violations of our moral core. And what's different, I think, about moral injury is it begins to erode our sense of worthiness as a human being, that we begin to lose our sense of who we are, why we're here, and really it begins to erode our sense of personhood in ways that are quite corrosive. So with that, we know that we experience moral distress in the pediatric ICU setting. And these are just some examples of the degree to which PICU clinicians, 30 to almost 60%, have significant levels of moral distress. We know nurses are more likely to experience moral distress, especially younger nurses. And it's associated with increased risk of PTSD, whereas junior physicians have a higher risk of burnout. And it may be partly explained by the tools and measures that we use. We know moral distress is correlated with burnout, and that it is often associated with end-of-life care, staffing continuity, and communication failures. There are also organizational contributors. Our team structure and dynamics, the supports and time and resources that we have available, care processes, things like staffing and how we have autonomy in our professional judgment, and also increasingly the impact of societal and systemic issues. And I can say in the United States, our sense of division and disconnection from each other is really finding its way into our clinical settings in troublesome ways. So when you think about those experiences, there are a whole range of responses. Sometimes we start with a narrative, one I've heard probably thousands of times. Why are we doing this? And I would suggest to us that every time you say that, it ought to be a clue that there's an ethical problem here that needs attention. Instead of just repeating it, to use it as an invitation for inquiry. Often we feel depleted. Sometimes we feel angry and powerless. We feel cynical that nothing ever changes. We may feel defensive. We may also feel guilty about who are we letting down, or even apathy. So that is a reality. And there's been suggestions at times that, well, why can't we just get rid of all this moral distress? Well, I'm going to propose that perhaps our response to moral distress is not a failure. It is a signal of our moral conscientiousness, of our basic goodness. If we did not notice these violations, of our values, what kind of care would we be providing? So instead of seeing this as, oh, this is the evidence that I'm just not smart enough or nimble enough or creative enough, but rather it's because we care that we experience moral distress. So what's the other side of that? His Holiness the Dalai Lama says when we meet real tragedy in life, we can react in one of two ways, either by losing hope and falling into self-destructive habits, or using the challenge to find our inner strength. And that's really the basis for our work in moral resilience, is I kept asking myself, so what else is possible? Is it that we're just going to be in this suffering forever and there's no way out? And so we began to explore this concept of moral resilience. And this is our current definition: the capacity of an individual to preserve or restore integrity in response to some kind of moral adversity. And I want to be really clear. We are not proposing being complacent, being acquiescent, or even putting a positive spin on a really difficult situation, or putting all of the responsibility or blame on the individual. Quite the opposite. Moral resilience is really focused on how we can reorient our energy, our resources, and our attention to restore our agency, our integrity, so that we can make choices that reflect who we really are and why we're here. So in Japan, the image that we associate with moral resilience is that of kintsugi, of taking a broken piece of pottery and instead of throwing away the shards of that vessel, to put them back together using golden paint and cement, not to turn away from the broken parts, but to actually honor them into a new vessel, to be able to see how we incorporate these experiences into who we are now, and to use them as fuel for growth and really integrity preserving action. So we did research. We came up with these 6 pillars of moral resilience: personal and relational integrity, buoyancy, self-regulation and awareness, moral efficacy and competence, and self-stewardship. Now, we don't have time to go into all of these in the depth that I would love to do, but I want to give you a flavor of what each of these elements really point to. The first one is integrity. And when you look at the word integrity, it starts with I for a reason. We have to know who we are, what we stand for, how we can live our values rather than talk about them, how we can be curious and inquire into these situations to discover what will really serve, not what we want necessarily, but what will serve. Integrity requires of us to ask hard questions, to speak out for what we stand for, to really listen to that call of conscience. And I mentioned before that our moral conscientiousness includes listening to those signals that say danger, pay attention, values are at stake here. Sometimes it requires courage to do the right thing, to take principled action. And sometimes the right thing to do is not to take action and to be responsible and accountable. Kaz Tanahashi, who is a Japanese translator, gave me this translation of integrity in Japanese, which he translated as whole oneness. And that is the second part of integrity, which is our relational integrity. That is how we are with one another. We have to know who we are first as individuals, but to realize that our personal integrity is intertwined with the integrity of others, that it is an embodied state. We resonate with each other's integrity. It encompasses our professional values and our commitments, our codes of ethics, and it recognizes our shared interdependence, our shared humanity, and creates a space where no one is left out and really honors our diversity and is inclusive. The next piece of moral resilience is buoyancy. And if you think about all of you are already resilient, you would not be a PICU practitioner if you weren't resilient. You know what it's like to be in that flow where you can meet the challenge and keep flowing along without too much angst. But there are times, such as these potentially morally injurious events, moral adversity, that knock us out of our resilient zone, that ability to kind of be in the flow. And we know we have some predictable responses. Sometimes we're stuck on hyperarousal, where we're sort of hypervigilant. Think about COVID. I think we all were in the hypervigilant stage for 4 years or more, where we can really be stuck on that sympathetic high, or on the other hand, equally dysregulated, we can be shut down, depressed, disconnected, exhausted, fatigued, numb. So the other part of moral resilience is our ability to resource ourselves so that we can get ourselves back into that resilient zone where we can be more clear, where we're able to see things clearly and respond rather than react. One of the tools that helps us to do this is mindful awareness, self-awareness and self-regulation. Simple skills to get our nervous system calmed down when it gets activated, and to be able to use these processes of mindful awareness to build the neural pathways that we need when crisis occurs. So that's the third, self-regulation, self-awareness. Next is moral efficacy. And this is the part of ethics that most of us are most familiar with. This is the decision-making tools. This is our knowledge, our skills, our ability to recognize and respond to ethical questions using a systematic process. And those skills are necessary for us to feel capable in responding to these ethical issues. The last piece of moral resilience is self-stewardship. And I want to say, this to me is one of the most important parts of moral resilience. We have an article that will be coming out in May, I believe, in the Critical Care Journal, specifically on this topic. This is the invitation to know ourselves intimately, and to be able, for some reason, I can't share my screen right now, but to be able to responsibly and mindfully manage our own personal resources, to be able to notice our limits and respond with compassion to them rather than judgment, and to really choose actions that are wholesome and healthy. So when you think about our engagement in moral distress, we want to be able to strengthen what is already present, and to be able to do that in a way that allows us to be whole, to be healthy, to be able to meet those challenges in ways that don't deplete us further. So,
you should be able to share your screen now, Cinda. Apologies.
Okay, sorry.
Try it again.
So, hold on, now I got to get back to you. When we think about this, I just want to encourage us to think about the narrative that we tell about ourselves. And one of the ones that I find very concerning is this idea that we don't need resilience. I would counter that to say we are resilient. Sometimes we just need the tools and skills to access what's already inside of us. And there are clear mechanisms for doing that. And we have been implementing now since 2016 the Mindful Ethical Practice and Resilience Academy. We have demonstrated statistical improvements in ethical confidence, competence, mindfulness, work engagement, resilience, and decreases in depression, anger, emotional exhaustion, and intent to leave. So I want to leave you with that and the idea that it is possible to measure moral resilience, and we would invite you to consider how you might be able to approach this question from a both-and perspective. The reality that moral adversity is part of our practice. It is part of being a critical care clinician. And there are strategies that we can use to reduce the detrimental impact of those situations on ourselves, on our teams, and ultimately for our patients and their families. So I think I'll stop there.
Thank you very much, Cinda. Very inspiring presentation. Really loved it. And we'll take questions towards the end. Please write your questions on the chat. And we are ready to leave the floor to Andrew Argent, who is going to speak on the role of physicians in supporting nurses in PICCS and reducing moral distress, and so on and more. So please, Andrew, thank you.
Andrew, I would like to introduce Dr. Argent, who is actually retired now, pediatric critical care physician from South Africa, from Red Cross Children's Hospital. He is an incredible leader in his field, has trained a number of people over time and made a difference in the lives of many patients, and continues to be involved with this community actually even today by participating in professional activities as well as participating in webinars like this. So Andrew, the floor is yours, and he can share about his experience of how can physicians support nurses in addressing moral distress. Thank you.
Thank you, and thank you very much for that very kind introduction. It really is an honor for a doctor to be speaking in this particular forum. And yeah, I hope that I can contribute to this particular team. But perhaps to start off with, what is my context? I'm coming from having spent many years working in Cape Town, South Africa. And South Africa, of course, is a upper middle income country. It doesn't have the resources of many rich countries, but it has a lot more than most parts of the world. That's a view of the Children's Hospital in Cape Town. And that's a view of the ICU, which I worked in until a few years ago. As you can see, there's no shortage of fancy equipment and patients there. But perhaps you can get a sense that the nursing ratios and the level of staffing that we have in this ICU is perhaps a little different to that of some of the richer countries. But this ICU puts through approximately 1,400 patients a year and covers a wide range of supports, including ECMO, renal replacement therapy, and a whole range of respiratory support. And so, as you've heard already, in that sort of context, we have among nurses and doctors, not to mention the other professionals in the area, very high levels of burnout, stress, and moral distress. And we have to start asking some of the questions about why and what contributes to that. I think we do have to start by saying that, in fact, we have professions from different backgrounds working in the ICU. And actually, we have quite widely divergent training, expectation, working conditions. And although we say we're part of the same team, we work together, there are in fact huge differences and gradients in income and in status between doctors, nurses, and other professionals in the ICUs. And that obviously creates a problem. It strikes me as being extraordinary in our country that nurses do their entire training in a completely different institution to the doctors. We even end up speaking somewhat different languages. And certainly in South Africa, there's an expectation that nurses will not use medical terminology in the nursing records. And so there are challenges about, well, how do we talk to each other if we don't even use the same language? And if we're really going to look after patients, we have to make sure that we get multidisciplinary, interdisciplinary, and patient-focused team function to really work. I think Cynthia has already highlighted some of the stresses, but I think it's important to note that we work with high-risk patients. When I started out, the mortality in our ICU was about 15%. That's probably down to about 6%. But there's a huge emotional impact of the patients we see on a daily basis, what happened to them, the traumas they've actually gone through. And if we think any of us are untouched by the emotional impact of what we see, we're being utterly naive. There's also a very substantial task load. They're just, the more complex the care gets, the more things we try and do, the more processes and details we have to get right all the time consistently. And that's in a context of working hours that somehow have to work 24/7, which inevitably means that people are working shifts. And for nurses, that often means 12-hour shifts, working nights and unsociable hours. And in South Africa, nurses are often working 6 months or more of night duty every year. That has to have a huge impact. And throughout this, we have to make difficult decisions about what we're going to do for patients. And underlying that is this sense of our own fallibility and the potential consequences. I can remember standing at the door to the ICU with an adult intensivist, and he just said to me, I couldn't do it. The thought that something I did wrong could affect someone for the next 70 or 80 years is almost too much to tolerate. And yet that's what we do every day of our lives. So how do we address that? First of all, we have to function as a team. We have to communicate, and the communication has to include not only the facts, the plans, but also our concerns. And that includes our emotional responses to what we're being asked to do, what we're being asked to contemplate, and what we're asked to deal with. We have to talk about issues such as the senior nurses constantly being faced to look after the sickest patients with the worst outcomes. I know that at Red Cross, often the nurses didn't want to take on the management of patients with severe burns. And when you knew that there was a very high risk of mortality for those patients, that those patients' lives were incredibly painful and difficult, you started to think, hang on a moment, to ask someone to stand at the bedside for 12 hours a day, day after day, is an incredible imposition on them. Now, of course, if they do that job well, there's potentially huge satisfaction and a huge sense of really making a contribution. But we have to understand that there is an impact from that. And then underlying that, we have to understand that all of us, every single one of us, gets things wrong every single day of our lives. And unless we're prepared to admit that, and unless we're prepared to create structures that will help to pick up our mistakes, to ameliorate them, and make sure they don't go through to impact the patient, we're also going to have problems. I just wanted to pick up some of the issues about communication. There was a paper that fascinated me some years ago, where nurses and doctors working in the same ICU were asked to keep records of adverse events. And over the period of that study, there were about 210 adverse events. And what's fascinated me, that the one database with the doctors had something like 112 incidents. The nursing database had something like 143 incidents. And there were only 44 in both databases, which means we're talking about different things. We really need to be sitting down to make sure that we agree on what are adverse events and what needs to be reported. Here's another story that absolutely fascinated me. This was a patient in an ICU in the US who didn't look that bad, but he had a very high lactate level. And they were calling in specialists, thinking of cranking up the inotropes, giving fluids, giving more interventions because of this lactate. And then fortunately, one of the patient visitors, who happened to be a phlebotomist, said to the nurse at the bedside, I noticed that when they took the blood, they put the cuff on for a very long time. Do you think that could have affected the lactate? And of course, she was right. But what does it say about the teamwork around that bedside that a comment from a visitor was picked up by the nurse and translated through into how we actually look after the patient at quite a complex level in ICU? So if we're talking teamwork, the team around that bedside has to literally include everyone there. I wanted to highlight something about lean healthcare. And lean healthcare, I think many people have different perspectives on it, depending on their experience with lean practitioners. But what I do want to pick up from the literature here is that the essential dynamic is continuous improvement, value creation, unity of purpose, and you can see that, but respect for frontline workers. And if you go and you read through the Toyota methodology, the lean healthcare, what you'll see is that there's an acceptance that the person at the bedside is the person who knows best and has the best and most detailed sense of what's going on. And again, we have to understand that in our context, that is the nurse. What we did at our hospital were to try and put in some interventions. One of them comes out of the surgical checklist. But it's fascinating to see what happens when at the start of your ward round, you say to every single person around the bedside, who are you and what is your job today? How it suddenly enables people to focus what it is they have to contribute and what it is they need to focus on during that ward round. And I believe that created an opportunity for people to talk about their role and create an expression of what they're concerned about. We also tried to implement a daily goals list. And the daily goal was essentially saying to each person around the bedside, how will you know that you've had a successful day at the end of today? What should you have achieved that'll help you know we're going places and where we want to? And again, that helped to create this focus of who are we, what is our role, and to try and give a voice to every person around the bedside. Likewise, we tried to implement handover processes. So those were some practical things that we could put in there. I want to share this particular quote with you that came from Wayne Derman, who's a sports physician. And one of the tasks he took on was being a sports physician to Paralympic athletes from South Africa. And what he pointed out was that actually one of the core elements of resilience for that group of people was humor. And I suspect that we need to talk a little bit more about using humor in our environments. It doesn't take a lot to remember that if you can get people laughing at the bedside, you can actually say things to each other that you would never be able to say if you were looking solemn and sad. Part of that is we also need to celebrate our success. We often focus on when we get it wrong, when patients don't have the outcomes we want. But actually, the vast majority of our patients get astonishing outcomes. And so we need to celebrate that. Celebrate with the families, celebrate with those children when they come back to clinics, and celebrate with each other when we get something right and develop. And so finally, I just want to leave you with a sense that we can find ways of working together without causing harm and moral distress. It does require focus. It does require a lot of training to make sure that we are as competent as possible in all the clinical tasks that we need to do. But underlying that, I suspect that we need to start with a bit of humor, a deep mutual respect, and perhaps a little less concern about our own importance. So thank you for that. And I just leave you with that comment for the procrastinators amongst us. So thank you.
Andrew, thank you so much. Really food for thought, and probably many questions will come because you touched on several things that made me think for sure. But for the moment, I will pass on the floor to Janet Matson, who will speak on educational pathways and professional development. And please, Janet, the floor is yours.
I will speak a little bit about education. It's equal with professional approach. I mean, we can discuss that later. And I think it's very important because in the clinic, we have three concepts that we are standing on. It's the research, development, and education. It's the leadership, and it's the nursing care theory and clinical knowledge that we learn over time and that we use and rely on. It's also the shared language that we have. Let's see here if I can move. The role of the medical staff has changed over time. When we started out, we were a lot task-oriented. We were doers, and then we became teachers to teach each other. And we moved further on to become facilitators and to facilitate knowledge development and research also in the clinic. So it meant that we went from being task-oriented to become relationship-based. That will also make it very important that we also change focus a bit in the clinic, in the learning, and also in the task, because in the situation, the context is so much more than we just see, and we all interpret it a little bit diverse and different, depending on where we come from, what knowledge we bring, the experience we bring into it, what we pay attention to, what we read into all the signs, and working in teams or deciding the path for the clinical things that we have to do, the medication that we are going to give. It's all dependent on what we decide in the meeting with the patient and so on. About nurses, we share a vulnerable time with our patients for a very short amount of time. We might recognize them later on in town, but they will always recognize us. And it also requires us to step down from power to become partners with the families, with the children, and give them the control over their situation as much as they can. And then we need to negotiate, and we also need to compromise, and we also need to guide them in terms of the things that we know and can. So that demands that we have a lot of knowledge, that we are humble, and that we also build on evidence. To do that, and also to show that we can't expect everything of everybody, we develop a clinical pathway, and you can see it briefly here. So we kind of ask less of the novice and more of the advanced university nurse. Of the advanced university nurse, we also ask her to lead the change and to do research and to implement evidence in practice, to be a colleague, a mentor to the novice that will be doing other things, occupied with learning and seeing. Because the academical clinical work, the research activities we do, is a way to bridge in the gap theory and clinical knowledge and to bind them together in the situation, to understand, to take new measures, to understand what we are measuring and how to do it. So a model that we could agree on could be one way of, bringing the quality of care further, and also that we can understand each other, what the underpinnings are. So this is just a suggestion of a model. We use it at the Karolinska University Hospital, Children's Hospital, both for education, for research, and also for development. It's kind of the research process, and then you can do it more strict, or you can do it a little bit, more leisure if you want to, depending on where you are. It gives us the advantage that we all know where we are in the circle. So the culture in the workplace have a significant impact on how we choose to act and what we choose to see and what we choose to pay attention to. And we always learn when we are together. And we need to discuss what is good things to learn, what should I pay attention to. What we are learning in the clinic is also what we pick up, is what we decided that this is important. So we need to communicate between all the healthcare personnels that are bedside and that are working in the hospital, in the work. So we need to turn to each other and discuss to get a common language, also to decide what's important here. Is it just surviving, or is it doing it in a good way, and so on. So for the new nurse that comes, it could be overwhelming to see all this apparatus and all these mechanical things, and they need time to break through it, to really see the patient and also to see all the signs. So that's why we developed the ladder. So they know what they can expect from us, and we know that we can't put too much on them in the beginning. It's kind of a security that they can say, I'm not able to take on that before I have learned this, and you have provided me with the opportunity to. So it's kind of a joint way of saying, now I have reached the level where I can take on more severe sick children, or whatever they feel that they are able to do. And then we can also say, well, I expect you to be able to do this on this level. So it's not perfect, but it's a start. So this is kind of the competence ladder in the beginning, up to kind of advanced level number 2. They are consummates of research, and then advanced level 3 and 4, they start to develop research and new evidence and knowledge. So it's kind of a way to get them all the ways up and then to contribute what they've learned on the way later on. Because if something doesn't work, well, it's a shitty place to work in, and we get affected, as we heard here previous today. And we kind of get in disagreement, and maybe we have a conflict, we get frustrated, we terminate our work, we go to another employer, and so on. And we feel bad about it. But when things work and we feel safe, we can do great things. And it's always nice to do great things together with the peers, to do it in a team, because then you can share the joy of being important to someone else and to really contribute. And that's a really a driving factor for a lot of nurses. The research says so. And it's also one of the most important things to keep them at work, to let them be able to expand their knowledge, expand their person, but also to use it and be useful. So there is this ongoing interaction between learning patterns, the facilitation of the significant network, well, the team we work in, and what we can provide for each other. So from a clinical learning development point, it's important to attend to the caring culture, how we speak, how we act, what we find important, and how we should learn together. The caring environment allow for open discussions when it feels safe, when you feel that we are on a level that we can understand and share, where we have good leadership, we have leaderships that pay attention to us as persons, but also as a group, and also really take care of the patients, because that's something that's common for us. We want the children and family to have a good clinical experience when they meet us. So approaches to promote the scholarship of nursing care, I think, are very needed to develop clinical learning and growth, personal and team growth. And I think that could be a way of raising the quality of care that we are giving the critical ill children. So that's kind of what I brought to the table today. Thank you.
Ursula, I think you're muted if you're speaking. Thank you so much, Janet. This was wonderful, and wonderful to bring everything together through the learning ladder. I think that that's a very important hospital policy, as well as educational for health policy for developing further pediatric critical care nurses. I think we have one more speaker. Ursula, would you like to introduce our next speaker as well?
Yes, so our next speaker is Natalie Patterson. Natalie is from the UK. She's a clinical academic, and I don't think that Natalie is here yet. So hopefully she will join for Q&As. And she's a staffing expert. So her talk is on her work on critical care staffing. And we do have a recording of her presentation. So I think we're gonna move on.
Good afternoon, my name is Natalie Patterson. I'm a Professor of Clinical Nursing at the University of Hertfordshire and Imperial in London. And I'm going to be talking a little bit about staffing in critical care and outlining a bit of my work, my research from the Seismic R study. So my work is predominantly in adult critical care, but I hope to draw on paediatrics to sort of make it more relevant to this group. In terms of the background, we know that there's a scarce nursing workforce in intensive care globally, but to optimise the use of that workforce is absolutely essential to make sure that we have good staff well-being, staff outcomes, as well as patient outcomes and patient safety. And in the UK, our staffing models are determined by a service specification. This is the handbook for how services are funded within critical care and the wider National Health Service. And we work to a 1-to-1 ratio for the sickest patients that we term the level 3 patients in the UK. But I do realise that across the rest of the world, this might be as high as 1-to-2 or 1-to-3. During COVID, we saw a rapid expansion of ICU capacity globally, and this led to the adoption of very different models, stretched models, with many more support staff, non-ICU qualified nurses and other professionals, and we reached up to 70% at surge. But the strengths, weaknesses and costs, as well as the effects of the different staffing models in play at the moment, really do remain uncertain. We don't have a good evidence base for those. We do know that where you have lower nurse staffing levels and a higher workload, that does result in poor outcomes, not only for patients, but also for staff. But the ICU specific evidence is relatively limited, and I'll come on to that shortly with some work that we did previously. Studies tend to focus on the level of RNs, and that doesn't really help us understand some of the consequences that have been adopted in terms of the changes to staffing models, and it's unclear how those changes affect different outcomes. In a systematic review undertaken by our group for the seismic study, we found that mortality proportionately increases with a reduction of nurses on the ward or units. And we know from other evidence that it's associated with not only patient mortality, but also increased odds of nosocomial or hospital-acquired infection, hospital costs, but also lower nurse perceived quality of care and lower patient satisfaction, which is highly important. The group reviewed 55 studies in total, not quite half of which had strong internal validity, and looked at care process outcomes, costs, family satisfaction, and one study also looked at nurse outcomes. And patients that were included in terms of the outcomes varied between 30 and 160,000 patients. So there was a wide range of studies, mostly cross-sectional and no interventional studies. And the evidence showed that for higher levels of nurse staffing, that led to better outcomes for patients, staff and health services. In terms of the paediatric literature, there are relatively few studies around. There have been studies by Hickey and team in the States looking at the levels of nursing education and experience, where unsurprisingly there were fewer complications, where there were higher levels of nursing education and experience. Some qualitative work looked at the impact of identity and how education played a really important role in forming nursing identity, which in turn improved retention. And then there's other work around things like telecritical care nursing models, using things like primary nursing models for long stay patients in paediatrics, which is different from the adult world. We can see there are quite a few parallels in things like, the ability to provide comprehensive rehabilitation in the long stay patients, but there are quite a few areas of divergence, such as variation in population, family inclusion, etc. And it's really important to think about the healthy workplace where there is communication, collaboration, leadership, and how that has an impact on intention to leave. Again, that's been shown in the literature. I won't dwell on this too much, as I know this has already been covered by my esteemed colleague, but it is important for us to think about burnout when we're considering staffing. In our studies, we're not actually looking at burnout, but it's important to understand the context. We are working with a staffing group that are experiencing very high levels of burnout, much higher than other nursing groups and much higher than other ICU professionals. And we saw that during the pandemic that was heightened. And I think it's really important for us to think about this when we're planning our staffing models as well, and what we need to do to account for that. One of the issues we encounter within staffing is the way that it's measured. It's so heterogeneous in terms of the models adopted globally. There are ones that look at, whether it's nurses per bed, whether it's professional judgment, whether it's looking at the acuity of the patients rather than the dependency of the patients. Things that are looking at specifically tasks. Obviously in paediatrics, there are specific models like Cameo and Goshman. So there are a lot of factors that are influencing how we're looking at staffing, and this has an impact on the effect for staff as well. The impact of staffing on nurse outcomes was looked at in this systematic review by Bay in 2020. And they focused on several studies looking at intention to leave, burnout, turnover, and actually the evidence base is quite weak from this systematic review. But there have been studies since, such as the CANDID study, which is still in reporting at the moment, that talked about the intention to leave being quite high, particularly in relation to the COVID-19 pandemic. And we know from another systematic review specifically on pediatric ICU staff that the prevalence rate is between 42 and 77% for staff experiencing burnout in a particular dimension. So it's a really significant problem that we do have to tackle. I'm going to briefly provide an overview of some current research we're doing that's funded by our National Institute of Health and Care Research in the UK. And this is looking at staffing models in intensive care, and we're undertaking a realistic investigation of this work, together with my colleagues at Southampton, who led by Peter Griffiths, who runs the nursing workforce research group there, and who's done an awful lot of work, including the RM forecast work in the UK and beyond. And it's been really important for us to think about what we want to look at. So we aim to identify the key components of optimal staffing models for deployment in ICU. We've undertaken a UK survey across all ICUs, and this is adult ICUs in the UK, a realist investigation. So we are looking at detailed case studies across 6 sites with many interviews with staff and patients, network managers, organisational leads, and developing programme theories, and also undertaking rapid ethnographies. Just to sort of recap for those who aren't familiar, a realist evaluation helps us understand what works for whom, when and why. And a realist evaluation helps us to think about, when we're looking at these different models, what's needed locally and what's practical and pragmatic to provide. So it helps us in thinking about, scaling programs, because we have a program that we think might work, but we don't know how it works or for who. And this will help us unpick some of this. We've undertaken a large national survey to all of the nurse leads in the UK for adult ICUs to understand all of the staffing models within each unit. We're undertaking these case studies where we're understanding how decisions are made on an in situ basis using naturalistic inquiry, and looking at the impact on nurses, patients, families, that's direct care nurses as well as the nurses in charge, how decisions are made within shifts where you might need to move patients, move staff around, how skill mix is ascertained. We're shadowing to be able to understand and observe how these decisions are made as well across these 6 sites to gain both ethic and emic perspectives. In a later work stream, we've also been drawing together e-roster data, so that's the nursing roster data, and the case mix program data across these 6 units to understand the impact of models on patient flow, capacity and costs. And we're trying to examine different scenarios. And we've also got this simulation modelling element to our study, where we're doing a data linkage between e-roster data. So we've got over 1 million shifts that we're looking at across 60,000 patient episodes, and linking those to understand what it's like if you flex the staffing to a certain ratio, what are the likely patient outcomes. And in terms of the patient outcomes that we're looking at mortality at 30 days, and this is routinely collected data. And it was important for us to collect routine data so that we didn't have to prospectively collect this data ourselves. We're using nationally recorded data here. We're looking at quality adjusted life years, the level of care they received, the length of stay in hospital, organ failure, infection, the dependency on ICU discharge, the cost of ICU and the post-ICU stay. And ultimately, what we want to achieve is a clear picture of models of staffing in the UK, some realist synthesised guidance around staffing based on the case studies, policy and all of our information from the survey, and disseminated national guidelines around this, as well as a simulated model. Thank you. We hope to take this work forward in paediatrics in due course, together with Julie Menzies, and I hope to be around for questions very shortly. Thank you.
Thank you, Natalie. And I believe Natalie is here for questions. So I will actually try to unmute and ask everyone, all of our speakers, to start their videos, if possible. And we have had quite a few questions come in the chat. I just want to say this was a great overview of how one can think about addressing moral distress, both from a personal perspective and overall kind of cultural perspective, even from the presentation of Dr. Rushton. Then Dr. Argent spoke about how to address it as a physician, because nurses obviously have to work and partner with physicians. We heard a great example from Janet's presentation about how training pathways can help address that problem. And the last one was a great presentation about what policy solutions exist when we plan for the workforce, which is wonderful to hear. Always the great examples of the NHS system. So I would like to actually start with Cinda, and I know you responded to that question in the chat, but you shared some resources about how we can include addressing moral distress and preparing for moral distress, even in the university training. Do you mind sharing a little bit about your experience with that?
Sure. And I can share my screen if you like. We have had the incredible privilege of having a statewide initiative over the last 4 years. And within that, we've been able to develop 38 modules focused on values, ethics, self-stewardship, emotional intelligence, mindfulness, etc. And I put the link in the chat, and I can just show you. This is the website. And you'll see here where it says tools and resources. We have the opportunity to share these freely with you. So if you go in, you have to complete a form for the university. But once you've done that, you can access these tools and resources. And what you see this is the sort of map of all of the 38 modules that we have available. So if those are useful to you, there's a couple of simulations. We have 2 on EPAWS, which is a process for addressing ethical questions, values clarification, moral compass, on and on. So feel free to take advantage of those if that's useful. And to the point about education, we are using these with our pre-licensure students. I teach a course focusing on ethics, and we assign these modules that are self-paced for them to reflect on. And then at the end of each of them, there is a certificate that they can upload to demonstrate that they've completed them. So
Wonderful.
Happy to
Thank
share
you.
those.
Thank you for sharing. Yes, this is wonderful to see. And I know you put the link in the chat. Continuing on this question, several people asked about how we can improve education. That is, the education is truly multidisciplinary. And through education, we can address. Do any of you have any examples? Janet, maybe you do have any examples from your work? See if we can unmute you. Where it's a multidisciplinary approach to, again, addressing moral distress and resilience.
Yeah, we are right now working with such a project because we think that if we have psychological safety, we can start to learn. If we don't have that, we are so occupied with other things and not doing saying the wrong things, so we don't learn. And that will affect the patient, the children and family negative, because we are so self-concerned and we don't learn. So we have this ethics project going on where we have ethical coffee rooms where we discuss things that come up, ethical, things in work, but also, as Cinda said, some taped simulations, and then we also go into simulation, and we really do ethical situation in simulation. So we try to do that with our working groups in my 9 departments.
Great. Andrew, do you mind sharing a little? I thought it was very insightful in the papers that you cited when you said that nurses and doctors speak different language. I have never thought about it that way, but it's kind of interesting of what you shared. So you always point out that you work in a low-resourced area and setting. You know, what do you think can be done in that kind of an environment? Is it any different from some of the solutions that are shared here?
Look, in principle, I think the solutions that people have been offering are the same. The underlying principles are the same. I mean, one of the things that we've talked about in our setting is trying to improve communication between people. I mean, in South Africa, what you have are physicians who are generally much better off than nurses. And we also have the history of apartheid and what that's meant for various communities and how people of different cultural backgrounds relate to each other. So there's a real need to talk about how do we make sure that we're communicating honestly and adequately with each other. But to be honest, I suspect that's true across the world. The US has all sorts of people from Latin America and other cultures. So we need to be culturally sensitive there. I'm intrigued by some work from the aviation industry where they spoke about crew resource management, and where they do theirs, they focus on people in authority becoming more aware of what the people that work with them are thinking and can contribute. But importantly, they also spend quite a lot of time on teaching people can you be assertive without being aggressive, which is, are there tools and words and languages and ways of saying things that enable you to challenge what someone's saying without eliciting an aggressive response? And I think we need to think about how do we improve the communication at that level, particularly in moments when we're starting to get emotionally involved with this issue. It's affecting us and we're feeling deeply about it. So those are just some thoughts there.
Very interesting. Yes, I think we've seen a lot of contributions from the aviation industry and healthcare recently with the checklist interaction. And I recently listened to a presentation of someone who came from the military, where actually spoke a pediatric cardiac intensive care physician speaking to someone in the military, and the person said, "Okay, these are very stressful jobs in the intensive care unit. How long do you keep people there? Because in the military, we move them around. We don't keep people in a very stressful job for life, and that's actually not the case in our field and in our careers. So I definitely think that there's something that we can be learning from other industries, whether it's in terms of processes, but also how we manage the workforce, which I think leads me to our next question. Natalie, fascinating studies that you cited. I'm very interested in learning a little bit more about that, because policy field is I think we need to be thinking more about policy specifically around this highly professional and highly skilled workforce that we have in intensive care. What do you think can be done in terms of policy solutions across countries, or maybe even at a global level? How can we advocate for better policies to avoid burnout and to avoid this continuous stress and people leaving? I mean, obviously we can't always avoid pandemics. The pandemic actually put us in that kind of a situation, but any thoughts about this community, how they can be speaking? So let's see if you can unmute.
Hi, can you hear me now?
Yes, thank you.
Great, thank you. Yeah, I would say there are definitely policy initiatives. So for instance, in the UK, we now have a policy around professional nurse advocates, which are nurses who are given allocated time to provide restorative supervision. And they sit within critical care. They're critical care nurses. Sometimes they're full-time, sometimes they're part-time, but they are there to support nurses to be able to think about not only things like well-being, burnout, etc., and what they can do to support other nurses, but also to think about wider issues about how you might support nurses to move around, take on different roles, try new careers, etc. So that model has been really interesting and has now been enshrined in UK policy. So there are initiatives around, and there are ways that you can kind of, look at these things, but that does require engagement from, government, and that has required quite significant investment. And there's no new money for this, so it's still got to come out of the critical care budget. So I think that's also important to say. In terms of sort of wider policy around, ensuring well-being, I think that's really difficult because it's so culturally and locally defined, some of the issues around this, that you almost need to unpick that before you could employ any national policy initiatives. So I think there's something about a local responsibility for the organisation to be able to take these things on where they know that there are problem areas, for instance, to work on that. But then there's also the stuff around, trying to support your staff to be able to access, initiatives that are available, and that they shouldn't have to do it all in their own time. A couple of initial thoughts, but happy to take any more questions.
Thank you. Ursula, what questions am I missing from the chat? Did you notice anything? Wonderful responses.
There, yes. I think you've got them all. There were just some comments on what can we do, to manage the current exhausting burnout, pushing away many nurses. So quite a few questions on strategies, but you responded in many different ways. I don't know if you have anything to add as a panel to respond to this. Is this Cinda? Did I see you waving?
Yeah.
Go ahead.
So just a couple of things. One is, there's some really interesting work being done in the UK in using the Institute for Healthcare Improvement, Rapid Cycle Quality Improvement method. Amar Shah is doing some really great work with teams. And I think the next sort of wave, we talk about individuals and we're talking about these big policy issues, but the middle part is our teams. And how do we begin to use rapid cycle quality improvement to have teams have some control over the things that they want to change? It's the pebble in your shoe. What is the thing that at the end of the day leaves you feeling depleted? Maybe a place to start where people have a shared sort of experience about something that would really make a difference to them. And then through that, to use methodologies like rapid cycle quality improvement to make change and evaluate it. And then if it doesn't work, move on to another thing, which I think kind of starts to neutralize the feeling of overwhelm of a whole system that needs to change. To maybe we could start with changing our own local culture just by some simple changes in, I think we heard about Dr. Argent's suggestion of how do we start a shift? How do we have a huddle? How do we begin in a relational way rather than a tactical way? How do we create sense of belonging among our teams so that we don't feel so isolated and disconnected from each other? So I think that might be, a way to start, and perhaps use some of our individual strategies in a team setting, so we come together in a huddle and we can start with, the one good thing instead of the one thing that's wrong. What's one good thing that happened today to shift us out of that negative mindset?
And I think Janet mentioned that a little bit of how, sometimes nurses feel dissatisfied, leave a job, go to another, and it's exactly the same problem. And so I think what you're suggesting is that we have actually QI tools that we could make small changes and propose small changes to institutions. I actually have a question related to that, and maybe, Andrew and Natalie can speak to it a little bit. How do we convince institutions that this is important? So let's say someone does a QI project you know, they come up with a solution, but how do you convince your institution? How do you convince your senior physician team that this is a good thing to do? And I know that's a hard question.
Perhaps Natalie could start.
Thank you. I think I've just been unmuted again. Thank you. So for me, I mean, the evidence is very clear that if you support your staff, you keep your staff, you don't have the high vacancy rate, you know, that you can clearly link it to mortality, to morbidity of patients. So you've got very clear evidence around that that's now emerging. For me, that's the board level conversations that you need to have. So that retaining your staff, that you need to invest in your staff and looking after your staff to be able to ensure that you've got not only good patient outcomes, but also nurse outcomes. So those would be the sort of top line messages that I would be conveying, and we do convey to our boards.
Great. Andrew?
I think what's also interesting is to turn around and point out the cost of having to retrain new staff, take on new personnel, and the cost is not just financial. It's utterly exhausting to the senior staff to constantly have to be training, going through it. And one of the problems that I sometimes think we need to talk about more is, and it's some work that Manette Coetzee has alerted me to, that the time taken for nurses to become experts, so you move from being novices to competent to being experts, is actually considerable. It's in the range of 12, 15 years, and that relates to the diversity of our patient population. So if that's the sort of experience you need to really get optimal clinical care in the critical care environment, losing a senior nurse is a complete catastrophe. And it's got to be put in those terms. And so I think is that, and it brings a whole set of other resilience. The moment that you have a significant body of those senior nurses, the error rate goes down, the bad outcome rate comes down, the legal suits come down. It just makes total sense from a financial as well as a personnel and so many other issues.
Yeah.
And I would like to add what you said before, Andrew. It's so important to also have some humor and have fun at work. And that's a management thing, to allow us to work together in team and not have this wishing schemes or 12-hour schemes where we work and work and work, but that we work with people that we feel safe with, that we can be developing things with, and maybe also have a relationship without outside work with. I think those are very, very important factors to be able to go to work every day and to endure what we really do. So it's here management comes in very, very heavy.
Yeah, I think that someone said it, I think Natalie, you mentioned it in the chat, that often nurses are seen as a volume, as a resource, not as workforce that you need to develop, continue to engage. I think we have, we're close to the end, right, Ursula?
Yes.
We've had great, I think, great discussion. And I just want to finish, I'll let you finish, but I want to say one last thing is that's why I see that the community and professional societies like WFPICCS have a great role to play of pointing out to policymakers of how important the critical care, pediatric critical care nursing workforce is, how long it takes to train them, and how important it is to retain them. And retaining them means that you don't want them to be exhausted. And so I hope that we can get some learning from this, and maybe we'll chat about how we can continue and share some of the resources that were shared. Thank you everyone to the presentations, and for allowing me to co-chair here with Ursula. Ursula, please close it.
Thank you so much, yes, for being here. I mean, very, very interesting, many thoughts, many inputs, many resources that you shared. And we also wanted to tell you with BISTRA that we will have a second webinar, which will be focused more on policies to promote and increase nursing retention. So watch this space, and we'll definitely invite you all to be part of it. And thanks for being here. And just one last announcement. We do have our WFPICCS Congress in Cancun in June. And up to April 19th, there is the possibility of registering as an early bird. With reduced costs. So just keep this in mind if you're planning to go to Cancun and meet us there. So thank you so much. And we'll see you hopefully soon.
Thank you.
At our
Thank
next
you, everyone.
event. Bye-bye.
Bye-bye.